We're here today to discuss and share with you a vision that the National STS Database has developed and continues to develop and refine for international expansion of the database outside the United States. As the U.S. Navy has described itself recently as a global force for good, we envision this as a quality collaborative for cardiothoracic surgeons around the world. That vision, we hope, will improve the quality of care for patients suffering from cardiothoracic pathologies literally everywhere in our globe over time. I'd like to ask our panel members to introduce themselves.
I'm Moshe Pira. I'm the professor and chairman at the Department of Cardiothoracic Surgery at Hadassah Medical Center, the Hebrew University in Jerusalem, Israel. And I'm an STS member since 1995. And we're among the first international participating sites. And as such, I was invited to join this committee.
My name is Vinay Badwar. I'm Chief of Cardiac Surgery at the University of Pittsburgh Presbyterian Medical Center and a member of this task force on international relations in the STS database.
Hello, my name is John Puskas. I'm Associate Chief of Cardiothoracic Surgery at Emory University in Atlanta.
My name is Dave Sheehan. I'm at Massachusetts General Hospital and Professor of Surgery at Harvard Medical School. I chair the Society of Thoracic Surgeons National Database.
I'd like to ask Dr. Sheehan to comment from the perspective of senior STS database leadership and executive leadership. Why is the STS embarking on this? What's in it for the STS? And what do you perceive the advantages will be for people outside the United States?
Well, John, the database was started in 1989 with the goal of improving the care of cardiac surgical patients. And that still remains the fundamental goal. But a lot has changed in the last 22 years. The world has become a much flatter place. There's much more international interaction in every sphere of life. And we have many international participants in the STS database now. We also have the ability, through the enhanced use of digital media of various sorts, to exchange information on an international basis that we didn't have when the database started 22 years ago. So we have the combination of our underlying fundamental core mission of improving patient care, the progressive globalization that we're seeing in every sphere of life, and the practical ability to exchange data. And we think all those things have come together to make it just obvious to us that we need to expand the database so that we can offer a service to our international colleagues, improve the care of patients all across the world, and learn as well from all the many good things that are being done in other countries.
So, David, you commented on quality improvement in terms of patient care, assisting our colleagues around the world, and perhaps embarking on research. Earlier in your comments, you said cardiac patients, but we in fact are also now expanding in the General Thoracic database and in the Congenital Cardiac database. Is that correct?
Absolutely, and particularly in the Congenital database, there have already been extensive collaborations within the congenital community. So this will, in essence, systematize some of those less formal relationships that have now been going on for years. And we are definitely embarking on the same sort of initiative in general thoracic surgery. So this is not just adult cardiac surgery.
Dr. Shapira, you have been among the very first adult cardiac centers in the world outside the United States to join the database. Can you share with us your reasons? Why did you do this? And then we're going to ask you, what was the process like? And have you describe some of the obstacles and perhaps benefits that you may have witnessed thus far?
Well, I was fortunate to be trained and then later practice for almost 17 years in Boston University. And we were among the first U.S. participating sites. And just from when the STS database began, right from its inception, and it was very clear, and I was part of this process of seeing the STS database grow here in the United States and see the enormous value on all the aspects that Dr. Shaheen alluded to. And therefore, when I accepted a chief position at Hadassah in Israel, it was part of my vision. It was clear to me that it is essential to have a database as a tool to assist me as a leader in the hospital, in my department, to ensure quality for patient care, to be a tool that will assist me in administrative and business decision, a research tool. And for all those purposes, I thought that we must have a clinical database. Now, to be a standalone database would be very difficult because low volume and it would be just very futile. So therefore, it was just a logical process to be aligned with some or any of the international database.
Now, it's a robust database, as you say. Has it been burdensome to get this off the ground in your center?
Of course, and this is, we had to, there are multiple, I call them challenges. I don't call them barriers, I call them challenges. First of all, you have to, kind of have the hospital administration align with your vision, because it required resources, and being an international site, these resources have to come from the hospital administration. So you have to convince them that this is, that they will have some return over the long term on their investment. That's the first barrier. The second is to have your faculty buy into this product, because this is not something that has been mandated by any agency. It's not mandated by the government in Israel. It's not mandated by our professional society or by any body. So it has to be voluntary, and everyone has to buy into it. And then once you have the resource, you've put in the resources, you allocate the resource, and you have a buy-in of all your faculty, there is this issue of how to really do it. And there are plenty of challenges. The practical aspects of it are challenging.
Well, we're grateful for your help at the very beginning of this international expansion initiative. Dr. Badwar, you have been active in helping us reach out to South America and Brazil in particular, a very different region than the Middle East, but also one that has seen value in adopting the STS database rather than building a standalone or from scratch database. We don't have one of those members here with us today, unfortunately, but perhaps you can share with us, from their perspective, that experience in South America and Brazil coming on board with the STS database.
I think the South American and many other countries, but in Brazil, to speak directly, there's a renewed excitement of participating in this global quality collaborative. Brazil in particular is a very vibrant surgical practice, both in thoracic and in cardiac surgery, and the country's resurgence in the world stage that they have, they are having a renewed focus of quality. Now, as Dr. Shapiro just outlined, the similar challenges and not barriers, but challenges, as you eloquently stated, are present in Brazil and all of our other foreign partners, and that is the same aspects of finding the appropriate resources in our fiscally constrained times. And those hurdles are being traversed, but they've worked very closely on these things, and the similar challenges are also being faced in Brazil, and we suspect from our communications that these same challenges will happen in every one of our foreign partners. But if we continue to focus on that goal, I think these will be able to be traversed. But the excellent risk-adjusted modeling that the STS database holds, and the multiple checks and balances that the STS database does on patient data protection and de-identified data, I think some of the key merits of why participation in this global initiative is not only safe in terms of the country's data, but also challenges that these challenges can be traversed well and for the right reason. We
now have fully fledged and initiated sites in Turkey, in Brazil, and in Israel. I imagine that in different parts of the world there are different motives, or perhaps differently weighted or balanced motives, and perhaps different and differently weighted challenges to overcome. What are your thoughts on that, David?
Well, first of all, I think we want to make it clear that we are not, it is not our intention to compete with any of the excellent databases that are already in existence in some parts of the world. We aim to provide a service where databases are not currently in existence, and there will be differences in many aspects of the international expansion. Some countries may have a few programs, and we may have the entire cardiac surgery enterprise in a nation. In other countries, we may have one or two hospitals, and I think that will influence the kind of report that we generate, for example. I think in the case of a country with 5 or 6 or 7 programs and all of them come on board, we may well want to generate a report that's specific for that country. If it's just an isolated hospital, that's a different proposition. But there will be individual differences. And I think, as Dr. Shapiro pointed out, the legal aspects will differ substantially from country to country in terms of their privacy laws, transmission of data, and those sorts of things do create a bit of a hurdle for us that we've encountered in our existing program.
Dr. Sheehan, in the closing moments of our panel, can you describe for us all the manner in which OUS data is handled within the STS database and how reports are generated to the external sites?
Well, the STS risk model that all the results will be based on is going to be a U.S. Population. The reports from participant sites outside of the United States will be benchmarked against those results that are determined from the U.S. risk model. In the case of Israel, for example, if all the programs from Israel were to join, we could have a report for each hospital. We could also have a report, as we do for some states and regions in the U.S. right now, where all the hospitals for that particular state, region, or country, in the case of Israel, would be listed with their individual results, again, benchmarked against U.S. data. We can't create a new risk model separately for Israel because there simply aren't enough sites or enough patients. And one of the advantages we have of benchmarking against U.S. data is just the huge number of patients. It gives us a lot of statistical validity. So that's how we're planning on doing that.
That's a great note on which to end. As the world's largest medical database expands outside the United States to serve our colleagues and patients around the world. Thank you for your attention.